everyone. Thank you for joining from this third lecture for the clinical cardio class, the 3C of young cardiologists. Today, we have a case presentation on acyanotic congenital heart disease by Professor Dr. Sandeep Bansal, who will be discussing approach to shunt physiology. He is professor and former head of the department of cardiology, Vardhaman Medical Institute, which is Safdarjung Hospital in New Delhi. But before that, we'll be having case presentation by Dr. Mohit Goel. He'll be presenting a case of shunt physiology. He's a resident of KEM Hospital, Mumbai. And without wasting much of time, I think we'll give maximum time to Mohit so that he can have a lot of discussion around left to right shunt physiology, acyanotic congenital heart disease. So this is one of the important topics that is very often asked. So welcome, Dr. Professor Bansal, and welcome, Dr. Mohit.
Yes,
Dr. Mahajan will also, along with me, be joining in a while as we take along the case presentation with Dr. Goel. So, Dr. Bansal, you have any comments to make, and then we can have Dr. Goel's presentation.
No, thank you. It's an honor and privilege to be a part of this. I always love teaching and look forward to your case presentation, Mohit. And thank you, Dr. Kamal and Ajay Mahajan, my very good friend. So thanks to both of you. And please go ahead and start your presentation.
yes.
Welcome, Mohit.
Uh,
Go
good,
ahead.
e- Good evening, respected teachers. I'm presenting a case of 8-month-old male child hailing from Lucknow, Uttar Pradesh, born out of non-consanguineous marriage, full-term normal vaginal delivery, cried immediately after birth. Birth weight was 3 kg. No history of NICU state after birth. Presented with chief complaints of failure to thrive since birth, feeding difficulty since the age of 3 months, one episode of lower respiratory tract infection at the age of 3 months.
Okay, so
Patient was
that's your history. We can discuss in between, Dr. Kamal, just as we do in the exam.
Yes, sir, absolutely. This is like a mock exam. Absolutely.
Okay, so so this is your history.
yes,
So
sir.
this is a 8 months old child, failure to
Yes, sir.
thrive since birth, right at. I mean, generally, when do we say that there is a failure to thrive? Though I'm not a pediatrician, but there is some bit of pediatrics that all of us learn as we study congenital heart disease. So, um, while you can have cyanosis since birth, but how do you diagnose failure to thrive?
Uh, so according to parents, there is a, a weight gain is not adequate
Yeah.
according to age.
So generally there has to be a certain increase in weight
Weight
that has to come in as the child grows.
grows.
Generally, we believe that the weight of the child should double by a period
Five
of about
months.
3 to 4 months, and by age of 1 year, the child should be weighing about 8 to 9 kilos. So, but apparently, this child has not gained weight, and that is why you are saying this is failure to thrive since birth.
Yes, sir.
And can you tell us about the feeding difficulty since the
Yes,
age
sir.
3 months?
Uh,
Because failure to thrive should have been hand in hand with feeding difficulty, isn't it?
yes, sir. It was at 3 months when the mother noticed that he was having difficulty in feeding.
Hmm.
Baby used to had a history of hurried breathing while feeding, sucks less volume of milk, and gets tired easily and takes frequent feeds.
Hmm.
And there was history of forehead sweating while feeding.
Hmm.
There was history of poor weight gain present, according to mother. There is history of one episode of fever with cough and increased respiratory rate
So
present.
did you try to elicit what was the weight of the child at say 3 months or at 6 months?
Uh, so, at actually they don't know the weight, but according to mother, she complained that he is not gaining weight.
Okay. Is he the first child?
First child.
So how does the mother know the comparison? Generally, see, there is something, one thing is gross, that there is no weight gain at all, and any mother would realize that the child is not gaining weight. The second way is by comparison. If the child is a second child or a third child, and they've seen their previous children grow in weight, then they know that. So what else? So what does all this tell you? The hurried breathing while feeding, sucking less volume of
The
milk.
history of suck cycle
So
is there.
what does that tell you?
Increased pulmonary blood flow situation because of feeding is in itself is a form of exercise to the infant.
No, they are all signs of heart failure in an
Respiratory
infant.
heart failure. Yes,
So they are signs of heart failure in an infant. What
yes.
else do we ask the mother when we ask about, history suggestive of heart failure in an infant?
Uh, the forehead sweating.
What happens when the child sleeps? What do the mothers complain? What happens to the child when they sleep?
Uh,
The
patient
mothers
gets
will
a
tell
baby.
you, the mothers will tell you that the that the bed sheet of the baby gets wet because of the sweating. So that's another very common complaint that mothers come with. Because one thing is, yes, sweating while feeding and uh, uh, stuck the feeding cycles, they are of course common, but more common is this. So where would you look for pedal edema in this child? Or where would you look for edema, I should say, in this child?
So there will be generalized edema more in the back.
Where
Uh,
there is a classical term mentioned for the children. Okay, go on. So he has had one episode of fever with cough, with increased respiratory rate, and which required
present at the age of 3 months, which required hospitalization for 5 days with
Hmm.
IV antibiotics and oxygen were given.
Hmm.
Other thing is, Mohit, when you're asked about the failure to thrive definition, or for that matter, any definition, like it may be the PA size, the ASD size, large size, small size, how do you define, or whether it's normal, abnormal? You have to say that for the aged and gender matched population below the two Z values,
Second
that is the
sentence.
statistical significance, right? So, and the Z values, weights charts are there, height charts are there, limb circumference, mid-arm circumference, head circumference. Also, what sir was asking, apart from the sacral edemas, etc., you also look at the fontanelles in children. So fontanelle fullness, fontanelle, whether it's depressed, will also often tell you the hydration status and volume status. So that's the other thing.
Yes.
About other Sakresak cycle, again, the pertinent question would be difficulty in feeding apart. It also means not only failure, but also it can sometimes be part of hyperdynamic or high volume output states.
circulation.
Right. And
Yes.
you can have high output cardiac failures as well. But very often it means that the systemic circulation is overloaded. That is what it means. The volume is too high, and that's why the patient gets fatigued easily. Yes, and sir has already told you, mother will tell you there'll be bedding, the bed
Yes.
sheet would be wet, and also the mother would say इसकी सांस तेज चलती है, सोता है पर सांस तेज चलती है, because they don't have what is called as the classical PND. So these are the PND equivalents in a child. All right. So that also you should keep in mind. Again, since birth, this is something that becomes tricky, as Dr. Bansal was saying. How would he know? Because this was the first child. So then you need it to be corroborated by grandmother, bua. So you should be prepared with, that
Yes.
in India, a pregnancy is never, usually in the rural areas still, is not just the father-mother story. It's usually a whole family story. So there is a grandmother, nani, dadi. They'll come in and chip in with whatever amount, and they'll say your child is not doing well, kinds. So that's the other history catch, that when you have, you should be prepared for ducking that bouncer with this kind of a answer, that provided you have taken that who else was around in taking care of the child.
Yeah.
Okay.
There is no history.
So this chest infection, does it qualify by definition to be called as a significant chest infection?
Sir, there is only single episode of lower respiratory tract infection. According to IAP definition, at least two lower respiratory tract infection in a year
See,
and
beta,
three.
that is the definition of frequent chest
Yes,
infections.
sir.
What I'm asking you is, does it qualify? Does any chest infection? What are the qualifying criteria for a chest infection to be called as a significant chest infection?
Uh, Sir, there should be a lower respiratory tract infection requiring hospitalization, IV antibiotics. Patient should be in respiratory distress.
Yeah.
Signs like
So this hospital admission, this infection qualifies to be called as a
significant.
significant respiratory infection because it
Yes.
had all the components. The child needed hospitalization, he needed IV antibiotics, and he needed oxygen inhalation.
Yes.
So these are, and then comes your question, the question that you were trying to answer. What are the criteria to say that there are frequent respiratory infections?
So for at least two lower respiratory tract infection in an year requiring admission, or in total three admissions of lower respiratory tract infection.
Yeah.
Requiring hospitalization.
2 in 6 months or 3 in a year. That's how they say it. Okay. Go on.
So there is no history of bluish discoloration of skin, nails, or mucous membranes. There is no history suggestive of cyanotic spells. There is no history of edema, oliguria, no history of seizure, focal neurological deficit, and no history of prolonged fever, skin lesions. Treatment history for these complaints, they went to private practitioner and diagnosed to have
Why
some
did you
congenital heart disease.
ask? Why did you ask for history of skin lesions?
So for infective endocarditis, prolonged fever, and skin lesions.
So, what are the skin lesions associated with infective endocarditis?
So fossler nodes, uh, painful nodules over the palm, road spots in the eye.
Okay. Why did you ask for history of seizure or focal neurological deficit?
Uh, so CVA can happen if it is Eisenmenger state, but not increase hyperviscosity can lead to paradoxical emboli and
So
stroke.
what kind of lesions can go into Eisenmenger in first year of life, if at all they do?
So mostly cyanotic, and large VSD usually go by 2 to 4 years.
No. Which are the lesions which Eisenmangerize very early? Those would be also, let me reframe the question. Sometimes some questions are asked to you by reframing, the answer remains the same. I usually give example of, causes of raised JVP in tetralogy, cardiomegaly in tetralogy, failure in tetralogy, S3 in tetralogy, you can say hypertension in tetralogy. All these answer is the same. Same way, when you are asked this question, the answer is same. So, which are the shunts present in utero? Same are the causes left which are responsible for early Eisenmangerization. Or
AP window.
which are the shunts which don't have any valve to prevent volume overload to the flooding of the lung. Let me still simplify. What are the post tricuspid shunts that you know of?
So VSD, PDA,
तो
AP window,
उसके आगे और क्या हो सकता है? उसके बाद एक और
AV
बात.
canal defect, AV canal defect.
Okay. Even beyond, what is there? So there is still a pulmonary valve. Can there be a shunt beyond it between the great vessels?
RSOV,
RSOV, why should a sinus rupture in a child?
no, no.
AP window,
AP window, yes, sir.
right?
Truncus
Truncus,
arteriosus.
Truncus arteriosus.
truncus.
These will. What is the survival in truncus? What is the average 1 year survival in truncus?
1 year, less than 10%, almost
Less than
90% mortality.
10%, 90% mortality in truncus on an average,
Truncus.
untreated. Okay,
Yes.
go
So
on.
what kind of, sorry, sir.
Oh,
Sorry.
please, Dr. Sharma.
So what kind of infections do you find in cyanotic heart disease, lung infections versus acyanotic heart disease, and why? Which kind of infections are more common in acyanotics versus cyanotics? So whenever you are asked a case of cyanotic or acyanotic, either the viva can go differentiating between the two based on either history or their differentials. And why do you think? So it can be a pink phallet. I can say this is a pink phallet. Why not a pink phallet? So see, so the anaerobic infections would be more common in cyanotic hearts.
Cyanotic heart
The
disease.
hypoxic, so you can have nocardiosis, tuberculosis, brain abscess. Those are the disorders. Anaerobic infections. Those are the infections. While in, as you see in the left to right shunt, the lung flooding, you know the mechanism, right?
Yes.
What is the
Yes,
mechanism
sir.
of increased LRTI in left to right shunt?
So there is dilatation of the pulmonary artery that compresses the bronchus, that causes mucus and air trapping.
So that happens much late, right? This child
Ciliary
hasn't
dysfunction.
got yet any dilatation.
Yeah.
He's just born.
There is increased pulmonary blood flow, mucociliary dysfunction.
Very good, very good. So two are different reasons. Poor mucus clearance is second mechanism. First mechanism is the increased pulmonary blood flow.
Blood flow.
Then comes your other things: three, decreased secretions, tracheomalacia, all those things will be other add-on causes. But commonest is flooding of the lungs, poor mucociliary clearance. People don't realize that mucociliary clearance is a big mechanism, how it's prevented, which is not so good in children. Though you may have flooding from other causes also, like you may transfuse a baby and there is hypertransfusion, but they don't develop LRTI pneumonia every time. They may develop hypertransfusion. They also have flooding, but it's a good mucociliary clearance which actually prevents from them getting a bad LRTI. Okay.
Yes.
Yes, Dr. Bansal, you were asking.
Yeah. No, I was asking him to go on.
Antenatal history, there is no history of
They
any
went to a
unsupervised
private practitioner. What happened then?
and diagnosed to have some congenital heart disease, and patient was advised to undergo one stage corrective surgery, but they did not follow up with the advice.
Okay. Why did you word it like this? One stage corrective surgery?
So because in some complex cyanotic congenital heart disease, patient may be requiring 2 stage or 3 stage Fontan surgery.
Okay. But you said there's no bluish discoloration
Yes.
at all. Okay.
Yes.
But you can still have cyanotic heart diseases. Yes.
Yes.
Okay.
Antenatal history, there is no history of any unsupervised drug intake in mother, no history of smoking alcohol intake in mother, no history of diabetes, hypertension, no history of radiation exposure to mother, no history of fever with rash in mother.
So can you tell me some drugs which can cause, when taken antenatally, they can cause problems? Some important drugs. Are you aware of a drug which was initially started to be given for pain, then it was being taken as a sedative, and it caused a lot of congenital defects? mainly musculoskeletal, but also some cardiac defects. That is
Uh,
very famous. Okay. Heard of thalidomide?
yes, sir.
Okay. What else? What
Uh,
anti-epileptics? Any anti-epileptic?
Anti-epileptic, yes,
Which one?
phenytoin and valproate.
No, which can cause a cardiac problem in the child?
Uh, Both can cause one phenytoin can cause aortic stenosis, pulmonary stenosis. Valproate,
So I'm not aware of valproate. What does it cause? But fetal, you can have fetal Hydantoin syndrome, as
yes.
we call it. Okay. What are the complications associated with smoking and diabetes?
Sir, diabetes, babies large for gestational age, and TGA is more common with large babies.
And fever with rash?
So rubella, congenital rubella syndrome (PDA)
In which
can be
month
there with
does,
the sensorineural deafness and cataract.
when is rubella important? When does it occur? When do we say it? If it occurs, then it can cause a problem.
This you should know, Mohit. This is a entrance question. I mean, entrance question, not an exit question. Which trimester? Any trimester?
She had fever with rash in the third trimester. Any danger? Okay, go on. Go ahead. चलो आगे चलो. Oh,
I
oh.
think, Mohit, are you there? He probably lost the signal. He's getting reconnected, it seems. So, yeah, Mohit, can
Yeah,
you hear
he's
So,
us?
there.
yes, sir. Yes, sir.
Yeah.
You
So
can
bring
reshare
back
the
your
slides.
slides,
So we
please.
were asking which semester, which trimester does the fetal maternal rubella is likely to cause the maternal rubella syndrome in the fetus. Are we audible? Mohit?
I can hear you. I don't know if Mohit can.
No more. I can. He was not moving. Now he's moving. So
Yes, sir.
yeah, yeah. So do you don't know the answer to this, or you?
Sorry, sir, I lost the connection.
So can you hear the question?
No, sir.
But okay, rubella syndrome, congenital rubella
Yes, sir.
syndrome. In
Yes, sir.
which trimester does the infection cause fetal abnormalities? First, second, or third, or are all three of them?
Not sure, sir.
It
Okay.
has to be in the organogenesis phase, right? So
Yes,
if you were to apply simple logic, so fetal cardiac
first and
anomalies,
second.
yeah, obviously. And what when is the fetal tube folding and all that completed? Are you aware?
So
When
starts
the
by
looping is
fourth week
over,
and over by
when is the
fourth to
cardiac
sixth,
tube activity or cardiac contractility now documented? Previously, it used to be 12 weeks and 8 weeks. Now,
six
do you
weeks.
know any number where people have documented the blood flow through the fetal tubes, the cardiac tube, as it is called, the first tube that
The
exists?
formation start by 21 days,
Very good. And the flow, you can document it as early as
4 weeks.
very good, 4 weeks. So, and when does the folding over gets completed?
So by
Folding of
six
the
weeks.
ventricles and the cardiac tube.
I'm not
So
sure.
that's where your Viva can go. Actually, your Viva can go on
Yes, sir.
organogenesis in congenital heart disease. Which arches disappear? What does the first arch form? What are the remnants of the arches that disappear? What is the ligamentum arteriosum a reflection of? Which side? What is responsible for double arch? Which arch does not disappear and cause bovine arch, or which elongation leads to anomalies like the uh, encircling of the trachea and the esophagus by the arch anomalies by the Comerel's diverticulum, as you know. So these questions can actually be asked by based on arch, tubing, looping, activity, and fetal maternal rubella congenital maternal rubella syndrome. Any other infection that can cause cardiac anomalies that you know apart from rubella?
So torch infections.
Very good. Torch anomalies. So, what are the anomalies that are associated with rubella, and what are the associated anomalies with torch? Cardiac
So with
anomalies.
rubella, PDA is common.
And
PDA
PDA is
and
undergraduate. You
branch
will
pulmonary
answer. PM
stenosis,
will
branch
answer.
pulmonary artery,
Sorry.
branch pulmonary artery stenosis.
Very good. Peripheral PS or branch PS. Peripheral PS. Very good. Then
Yes. And in torch infections, VSD, convertempral.
absolutely VSD. So, an endocardial cushion defects, right?
Yes.
Right. So where do you get? So now, what are the associations of these in examination of a child who's just born? What is rocker bottom foot?
Club seen in Edwards syndrome, uh, club foot, associated clenched feet. Association is VSD and PDA, Edwards
Very good.
syndrome.
With VSD. So which other trisomies can be responsible and associated with
Uh, so
foot
trisomy 21
abnormalities?
Down syndrome as well as Patau syndrome can be associated with
Patau's and
VSD.
Edwards. Downs usually does not cause rocker bottom. Downs you don't
Yes.
get rocker bottom foot.
Yes.
Right. What are the other anomalies in maternal rubella syndrome? What are the peripheral
Uh,
signs?
Cataract and congenital deafness, sensory neural deafness.
Okay.
Okay,
What about,
go on.
yeah,
Yes.
go ahead.
Development history. Physical underdevelopment was noticed by the parents. Patient had social smile at 3 months, speaking monosyllables at the age of uh, 6 months, pincer grip at 8 months. There is no delay in developmental milestone. His firstborn child of age 8 months.
Why did you mention the age of the parents?
So advanced elderly female, more associated with Down syndrome.
Generally, age more than what?
30.
Yeah. Generally, if the maternal age is more than 30, there are greater chances of,
Yeah.
congenital heart defects. This is actually scarily more common in doctor couples because a lot of doctors have started to getting married late, so it's not uncommon in the doctor couples. Go on.
Yeah. So provisional diagnosis.
Yeah.
Congenital acyanotic heart disease with increased pulmonary blood flow with left to right shunt in CCF with failure to thrive. The possibility of shunt physiology.
Okay. So what are your possibilities? Pre-tricuspid shunt or post-tricuspid shunt,
So
and why?
post tricuspid shunt because pre tricuspid usually do not present with failure at an early age.
And among the two post-tricuspid shunts,
So
VSD
it could
versus
be
PDA, which is more
PDA.
likely?
So it could be either of above, but VSD is more common, more prevalent. So it could be
VSD is the
first,
most
possibly
common.
congenital heart disease.
Yeah, it is the most common congenital heart disease. So likelihood is more, and also with the given typical presentation, you based on history, uh, I don't know if it is possible to, unless it's a syndromic child, it is difficult to say whether it is, PDA or VSD as the cause, other than saying that VSD is more frequent than the PDA. Shall we go ahead, Dr. Kamal, or
Yes, sir. Yes, sir. We can go
yes,
ahead.
please.
So, yeah.
General physical examination. Patient is examined in mother's lab and is conscious and alert. Height is 70 centimeter, that is 30th centile for that age, and weight is 6 kg, that is below the third centile for that age. Head circumference is 42 centimeter, that comes at second centile. There is no feature of dysmorphic face, no abnormality of hairline, neck, back, or spine. There is no pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy. Temperature is normal by palpation. Pulse is 136 beats per minute, regular, normal in volume and character, bilaterally symmetrical with no radio-radial radiofemoral delay.
Just for my information, are you a pediatrician by your postgraduate degree, or you are an
No, sir.
internal
MD
medicine?
medicine. Medicine,
MD
sir.
medicine. Go on. Okay.
Blood pressure in right upper limb, it is 82 by 56 millimeter of mercury. In left upper limb, 80 by 56 millimeter of mercury. In right lower limb, it is 88 millimeter of mercury systolic. Saturation is 97% in both upper limb and lower limb. Respiratory rate is 42 per minute. There is no intercostal recession or chest retractions.
So all these baseline parameters, they are normal or something is abnormal?
Sir, weight is less than second centile.
Yeah.
And tachypnea, rate, respiratory rate is 42 per minute.
Yes.
What do you mean by happy tachypnea, Mohit? So, happy tachypnea means patient is tachypnic, but doesn't look sad or tired or fatigued. That would be in when he doesn't have to labor for the breathe, right? But he's breathing fast because he's hypoxic. So, what kind of shunt that would be? Cyanotics, right? Pink fallet. I think again we lost his connection. So pink fallet, again, sometimes they are asked in exam as to what are the causes of pink fallet. Yeah, Mohit, the happy tachypnea thing we were discussing. You're muted, it seems.
Yes.
Yeah, Dr. Mohit.
Yes, sir.
So
Yeah.
happy tachypnea, we said pink fallet. That's one example of happy tachypnea. Okay.
Go on.
Yeah.
Although this is rapid, but generally in a child, in a infant, something which is more than 60 per minute is more sinister. This is slightly less, but
Right.
still for a 9 months old or 8 months old, it might still qualify for tachypnea. Go on.
So this connection is slightly unstable.
Yeah. So usually it's the as Dr. Bansal sir was saying, it's the what they call pulse respiratory ratio. If the ratio is 1:1, it's really bad. 1:2, still bad. But normal, as you know, is the ratio is 1:4 or 1:6. That's what is expected of adults. But in children, that's not the ratio. So in children, something like 60 would be 1:2 for a pulse rate of
Yes.
120. That would qualify as a bad tachypnea. Yes, Mohit, go ahead to examination. Yeah.
So inspection and palpation. Trachea is in midline. Chest is bilaterally symmetrical with increased precordial activity. Apex impulse is seen and felt in left fifth intercostal space, just lateral to the mid-clavicular line. LV type of apex, hyperdynamic and diffuse. Palpable thrill is present in left parasternal region in third, fourth intercostal space. Palpable second heart sound is present in left second intercostal space. There is no parasternal heat, no other impulse, scar marks, sinuses, or dilated veins.
ठीक है. Go on.
Upper border of liver dullness is present in the right fifth intercostal space in the midclavicular line. Left heart border corresponds to the apex beat. Right heart border is substernal. Left second intercostal space is dull. On auscultation, S1 is normal. S2 wide variable split with loud P2 is present. No additional sounds is present. There is a pan-systolic murmur, grade 4 by 6, present in left third, fourth intercostal space in parasternal region. Harsh, high-pitch, plateau configuration. Heard best with the diaphragm of stethoscope at the end of expiration, radiating to base and apex.
Okay. There's a mid-diastolic murmur.
Okay, so what
Yeah.
happens to a VSD murmur
Yeah.
based on the size? So suppose it's a very tiny VSD or suppose it's a very large VSD. Does the murmurs change? Yes or no?
Hello, Mohit, are you there with us?
I think we'll again lost him.
Yeah, he's lost his connection with us.
I think he is doing his duty.
The intensity, okay, he can't hear us.
Yeah. So so the for the sake of our audiences, the two murmurs that can actually need not be pansystolic in VSD are a tiny VSD murmur and a VSD with Eisenmenger. The reason being that in a patient with very tiny VSD, the murmur will disappear because of the contraction, the VSD itself may close. So it may be early systolic as they call it. So early systole, you'll have left to right shunt, and then the VSD closes and the murmur may disappear. On the other hand, you can have early systolic murmur only seen in VSD with PAH because only some amount of blood will flow initially, and then the equalization of pressure will further hamper any shunt. So these two conditions you can have uh, actually a VSD. Both are extreme. Very tiny VSD and VSD with Eisenmenger, where the murmur
Yes,
is not pansystolic.
where it is not pansystolic.
So
Yes.
my next question to Mohit was going to be as to how do you then differentiate between these two VSD murmurs? And then the answer to that is the loudness of P2. So if
Yes.
P2 is loud, you know pH is there. The signs of pH, if they are there, you have palpable P2, parasternal heave, dilated PA, a pulmonary ejection click, or second dull left intercostal space. Uh, all those would go in with PAH compared to
Yes,
patient
the
with small PH.
interesting part was also the description of second heart sound that he had made. It's a
Yeah.
wide but variable second heart
Yes, sir.
sound,
Yes,
and the pulmonary component is loud.
right. Yes, Dr. Mohit, you're back. So,
Yes, I can hear, sir, but my video is no.
no issues. I think so. What is happening, Dr. Mohit? You are on a low bandwidth. You can keep your video off and you can
Yes, sir.
continue the presentation so that you
Yes, sir.
don't lose your network. No problem. So, we
So
were
what?
discussing about the murmur and
Yes, sir.
its. So, what is the importance of this mid diastolic murmur?
Sir, mid-diastolic murmur is because of increased blood flow across the mitral valve.
So in general, Mohit, what is the relation of the intensity of the murmur and the size of the VST? Small, Dr. Kamal mentioned very small VSTs or very large VSTs having gone into PAH. But in general, run of the mill, small, moderate, or large VST, what is the relation with the intensity of the murmur? Does it increase as the VSD size increases, or does it decrease as the VSD size increases?
So it decreases.
Yeah. So
The
generally,
loudest is with the small restrictive VSD.
yes, that is true. So how do you explain this wide variable split with a loud P2?
Uh, Sir, wide is because A2 is early uh,
A2 is early.
and loud P2 because of pulmonary hypertension has developed.
Yes, A2 is early
Uh, because of shunting of blood from LV to RV.
So in what other condition can you have an early A2 as a
Sir, in
cause of
MR,
in
ASD,
MR?
MR.
Yes. In fact, in MR also, it is considered as a very important feature of severe MR. If
Severe MR.
there is a wide variable split of second heart sound, it is attributable to early occurrence of A2.
Yes.
Okay, and the
So, Dr. Mohit, how do you quantify small shunt, medium shunt, and large shunt in a VSD
yeah,
on clinical
Yes, sir.
examination? Then we'll come to X-ray ECG. So,
Uh,
we can start from history actually.
so on clinical examination, on history, small VSD are generally asymptomatic.
Okay.
They they only present on routine examination as a
Moderate versus
pen
large,
system.
symptom-wise.
Large VSD present with symptoms of heart failure by 4 to 6 weeks.
Or
Early
they
presentation.
come with Eisenmenger. Actually, they Eisenmengerize early. So large VSDs would usually present with Eisen. What is the median age of Eisenmengerization in a VSD?
So 2 to 4 years.
Right.
earlier.
And very often a large VSD would Eisenmengerize as early as 6 months. You send it across to a CHI, to a pediatric surgeon, to a pediatric cardiac surgeon to operate a VSD. He'll tell you that we'll not operate because it's more than 6 months, and you'll have to a cath and tell them that yeah, patient is still operable. Uh, uh, and this variable split, does it tell you something about operability?
Yes, sir.
What does it tell you? So P2 is loud. I say there is PH. So what kind of pulmonary arterial hypertension
Hyper
is this?
hyperkinetic pH is there, sir.
Very good. Hyperkinetic
Yes.
pH. So hyperkinetic pH versus fixed pH. What are the features that help you differentiate? If we can answer this
Sir,
question first, and then we can come back to large,
yes.
moderate, and small.
Sir, in case of fixed pH, symptoms of heart failure will resolve. Baby will be symptomatically better from earlier, and on examination, murmur will disappear, and S2 will be single in case of fixed pH.
So
And on ECG
S3,
and
S3, MDM, variable second heart sound, still in symptoms of recurrent LRTI, still presence of cardiomegaly, because once a pH will develop, the plethora will disappear, cardiomegaly may or may not persist, and cardiomegaly may become small, and the LV forces versus RV forces. So when you feel the apex, when you see what kind of ECG forces are there, those will tell you whether the patient is still predominantly operable or inoperable versus which would again qualify as whether the patient has got fixed versus hyperkinetic. But MDM, S3, P2 variability are three important auscultatory hallmark of operability and health
operability.
reversibility, or what is the hyperdynamic or hyperkinetic pH being dominant. So most of the patients have both, but this is dominant. That's all you can say. Again, between moderate versus large, how do you differentiate? Again, the same things. If you have big shunts, you'll have flow. You have cardiomegaly, you'll have S3. Usually the QP by QS in such patients is more than 2.5 versus 2.2 or 1.5 to 2. You will not have this, but the rest of the findings. And 1.5, you will have only the murmur.
Yeah,
Sir,
a
Dr. Bansal?
lot of my talk has already been discussed.
Oh, is it? Okay.
Yes. Okay, no worry. Go ahead. Other examination systems are normal. So, with that, what is your final diagnosis? Hello, Mohit, are you there? We seem to have lost him again.
Again, as we were discussing S3, S3 versus MDM, we were also, you can be asked as to the amyl nitrate or the preload reducer agents, what happens to that murmur. So patients who have got fixed pH versus hyperdynamic, amyl nitrate will not have any impact on fixed pH. But with amyl nitrate, again, the hyperkinetic pH can actually disappear, murmur can increase and decrease depending on which cycle.
Actually, I tell my kids I have never used amyl
Use amyl
nitrite in
nitrite.
my life. Actually.
Right. So we were
So,
discussing this in last lecture on HOCM, that amyl
right.
nitrate is not available, and then we were discussing why to discuss it. The whole point is about understanding the hemodynamics and impact of systemic and peripheral vascular resistance, how they can be
Yeah,
altered by drugs,
for
and what can be the
HCM
potential impact on the murmur.
for HCM provocation, actually, even a sublingual nitroglycerin is good.
Right,
The
it is.
the
Right,
usual
it is.
sublingual nitroglycerin is good for provocation of HCM.
Right.
So we generally use that in our echo room.
Right. So, Dr. Mohit, you have any
Yes, sir.
other examination findings? Else you can come with your diagnosis.
So
Um,
give us the final diagnosis in this, or the clinical diagnosis.
yes.
Again, he is muted.
Uh,
Yeah, go ahead. Go ahead. Your final diagnosis.
yes,
Yes.
it is a case of ulcer situs solitus with levocardia, congenital acyanotic heart disease, increased pulmonary blood flow, shunt physiology, post tricuspid left to right shunt in the form of moderately large size ventricle septal defect, moderate pulmonary artery hypertension, sinus rhythm without evidence of infective endocarditis, modified Rose classification 3.
So why do you say post tricuspid?
Pansystolic murmur of uh, VSD.
At what age do you generally have presentation of pre-tricuspid shunts?
So when RV become more compliant after three 3 to 6 months.
आपने कभी बहुत छोटा बच्चा ASD के साथ देखा है who has symptoms?
नहीं sir, basically in third decade they present with failure.
So, okay, चलो
Yes.
ECG दिखाओ, because we are already running we've overshot on time.
So this is a 12 lead ECG with heart rate of around 150 beats per minute. Situs is solitus.
What is
There
the
is
characteristic feature in the ECG here?
Yeah,
Which
this
tells
is
you
a very characteristic ECG. What does
so
it
there
show?
is equiphasic R and S wave in mid-precordial leads V2, V3, and V4.
what's that called as?
The Katz-Weckel sign.
Okay,
That's
Katz-Wechsel phenomenon.
phenomenon. Yes.
Right.
Uh,
X-ray.
So what does it
Suggestive of
signify?
biventricular hypertrophy.
Yeah,
Sir.
biventricular
Hypertrophy or volume overload?
volume.
Hypertrophy, sir.
So what does what is the volume overload finding on ECG?
So Q wave in lateral leads V4, V5, V6,
And
along with tall R wave
all
and
T
from
waves.
T
All
wave,
T
T
waves.
wave.
T waves. Okay. Next, X-ray.
Uh, so this is a chest X-ray. If you use slightly rotated film, uh, cardiomegaly is present, sir. Probably sir, LV type. There is prominent pulmonary vascular markings are present. There is
I think we need to move on to the.
Right.
It's already 9 o'clock.
Yes, sir. Yes, sir.
So
So I think with that we can.
yeah, we'll thank Mohit for a
yes, sir,
wonderful.
yes.
presentation. And can I go to the
Yes,
actual
sir.
presentation?
Yes, sir.
Yeah.
Dr. Kamal?
Yes, sir. I think is the screen? Can you hear? Can you hear me, sir?
I can hear you
Yes,
loud.
sir.
Yeah. So now you can start sharing the screen. So with this, I
Yes, sir.
invite Dr. Bansal. Dr. Mohit, you can stop sharing. Dr. Bansal can start presentation. You can stop sharing. So now with the case presentation that we've already had, thank you, Dr. Mohit, for presentation.
Yes.
It was good discussion. Now it's time to learn from the master. I invite Professor Dr. Bansal. So as this is the third lecture in the series of clinical cardio class, uh, and Professor Dr. Bansal is going to take us through with the approach to shunt physiology in next 30 minutes or so as to how to approach this case. Can we hand over the
Okay,
presentation to Dr. Bansal, sir?
thank you.
Yeah.
I hope my slides are visible now.
Yes, sir, they are. Please.
Yes. Okay. So, thank you. This is uh, uh, a lot of things that I'm going to tell, we've actually already discussed. But let us see how do we approach a patient of shunt physiology. I'm not going into too many nuances. The basic thing that we need to know is whether the shunt is small or the shunt is large, and how do we differentiate between the three different types of left to right shunt and shunts that we have, and how do we distinguish between small, medium, and large shunts, and determine which are the significant shunts. So, this pretty much summarizes the different congenital heart diseases that we have. And let me see if I have a pointer here. So, what we are talking about is cyanotic or acyanotic heart diseases. They may present with pressure overload or volume overload. Generally, the volume overload states have left to right shunts, or they may have regurgitation lesions. So these left to right shunts, which lead to volume overload and are a part of acyanotic heart disease, are the main shunt lesions that we have. Uh, in this cyanotic group, we also have two types of lesions. One is the decreased pulmonary blood flow group, wherein you have shunting from right to left, which will cause cyanosis. And we have other diseases which are, again, where there is a right to left shunt, which are highlighted here, wherein there is an increased pulmonary blood flow. So the cyanosis may actually be very mild, but there is a mixing of blood, and that leads to cyanosis, and there is no obstruction to the pulmonary flow, which leads to increased pulmonary blood flow. But we need to understand that it is only these acyanotic shunts which need to be quantified, because in cyanotic heart diseases, it is the obstruction to the pulmonary blood flow which is the most important determinant, or the development of pulmonary arterial hypertension or Eisenmengerization. That is the one which will be important. So the main focus is going to be these acyanotic left to right shunts. Now, if we of the major features of these shunt lesions. So wherever the shunt is taking place, the volume of blood overloads the chamber that it feeds. So typically, if it is occurring before the tricuspid valve, then there would be overloading of the right atrium and the right ventricle. And if there is overloading beyond the tricuspid valve, or as we call it, the post tricuspid shunt, then there is overloading of LA and the LV. The The other important thing is that the magnitude of enlargement of this chamber is proportional to the magnitude of the shunt that is taking place. And likewise, the pressure of the chamber uh, to, to which the shunt is taking place, it would rise, if there is right ventricular outflow tract obstruction, or there is distal pulmonary arterial obstruction, or there is pulmonary arterial hypertension. There can also be what was discussed, the dynamic, increased blood flow, pulmonary hypertension that might take place due to transmission of pressures because of the shunt. We also should need to understand that the gradient between the two chambers is proportional to the magnitude of the shunt size between them. So if you have a very large defect with a large defect between two chambers, the pressure gradient between the two chambers is going to be less. So this is how the shunt lesions are. We typically have these cardiac defects, which may be pre-tricuspid, which, volume overload the right side. There can be atrioventricular septal defects or ventricular septal defects, or PDA, which cause volume overload of the left side. They also cause markedly increased, all these cause markedly increased pulmonary blood flow and exposure of the pulmonary vasculature to higher pressures, which causes pulmonary hypertension. So these are the gross physiological aspects. We also need to know, uh, this may be a little premature at this time, but it is important point, so I tried to make it at this time, that the diagnosis of shunt lesions is made up on the basis of increase in the oxygen saturation, or step up at the level of oxygen saturation. And the significance of a shunt is determined by the QPQS ratio, or the increase in the pulmonary blood flow as compared to the systemic blood flow. And mostly any shunt which is more than 1.5 is deemed as significant. A step up of at least 7% at the atrial level, or 5% at the post tricuspid level, or 7% at any level overall is suggestive of, and this is the average increase, mind. The On the other hand, if we have been able to take only one measurement, then the cutoff values are these, which are given on the right side of the screen. So, in a similar manner, if there is a step down of more than 2% in the aortic saturation, and the saturation is less than 92%, this can be suggestive of right to left shunt. But as I said, quantification of the shunt is most important, mainly in the left to right shunts. And so there we are. What are the differential diagnoses of pre-tricuspid shunts? They would include typically atrial septal defect or partial anomalous pulmonary venous drainage. There are others which are highlighted here, but they are not so common. The ventricular shunts, typically, the post-tricuspid shunts include typically the ventricular septal defect, and the great vessel level defects typically are PDA and AP window. So these are the typical shunts that we have. Uh, as far as the cyanotic heart diseases are concerned, in the top physiology, there is a step down at the ventricular level, or the ventricular to aorta level, there is a step down. So typically from left ventricle, when you're pulling back into the aorta, there would be a step down. In transposition physiology, this is a very standard thing which we are taught when we are, studying the oximetry runs. One of the first things that my teacher would tell us, you see what is the concentration of oxygen in the femoral artery versus the aorta and the pulmonary artery. And if PA is more than femoral artery, then there is a transposition physiology. If the oxygen saturation is the same in the different chambers or the four chambers of the heart, then this is a admixture physiology. These are very basic things. So these are some of the right to left lesions or right to left shunts that we need to know about. But as I said, the quantification or the physiology is more important in terms of the acyanotic heart diseases. Now, as far as the ASD is concerned, we need to understand that the shunt should be more than at least 1.5:1 to be, leading to symptoms and needing correction. So there is most of my data actually is taken from the uptodate.com, so it is easy to follow. I can also share these slides if it is required. In a study of almost 480 patients, it was noted that if in those patients only wherein the QPQS was more than 1.5:1, more than 50% of the patients were symptomatic. And the most common symptoms associated with large ASDs include exercise intolerance, fatigue, and breathlessness. And it is a rare patient who would develop overt heart failure symptoms. Now, as far as the clinical findings are concerned, um, because the shunt starts quite early in the age and it causes a distension of the right atrium and the right ventricle. So left precordial bulge is a finding, important finding, because the enlarged chambers are pounding on the skeletal chest cage of the small baby. There is a hyperdynamic parasternal impulse, again, because there is an increased flow on the right side. The PA in the pulmonary artery impulse can be felt, again, because of the same reason. The right ventricular impulse is important, and this right ventricular impulse is, you know, uh, felt in the left parasternal region or in the substernal region. And this may be sustained if pulmonary hypertension is present. And occasionally it may occur just because of increased flow, because leading to elevated PA pressure. As far as auscultation is concerned, there is an you know, we know that the gradient between left atrium and right atrium is very low. So the the murmurs or the auscultatory events are generally related to the the flow across from RA to RV, and then from RV across to the pulmonary artery. So typically we have an ejection systolic murmur across the pulmonary valve. That would be the left upper, parasternal border. There can be an ejection systolic murmur if the ejection systolic murmur is present across the pulmonary valve. Then this is suggestive of a large shunt. If it is loud, it suggests that there is an obstruction across the right ventricular outflow tract. Another very important thing, and without which we don't make the diagnosis of a significant ASD, is the presence of a mid-diastolic murmur across the tricuspid valve, which can be heard either at the left sternal border or the substernal area. Please remember that when we are talking of right ventricular events or right sided events, the substernum is extremely important. So please do make it a point to auscultate the substernal region. Also, if the shunt is large because the defect is large, pulmonary arterial hypertension develops. Of course, as we were talking, it develops generally in the at least in the fourth decade or the fifth decade, but sometimes it can develop a little early. If it occurs quite early, then it has to be an AV canal defect, a partial or a complete AV canal defect. That means there is a atrial septal defect and there is a ventricular septal defect also, or another form of atrial septal defect and not the classical secundum ASD. So, as far as the ASD sizing is concerned, and this is again taken from the uptodate.com. The shunts are described in terms of size. However, we need to understand that these are for an average built, adult, and in a child or in a person with a lesser body surface area, these may be different. But this is grossly the figure which is available. We also need to understand that ECG, whenever there is a significant shunt across the atrial septal defect, one of the earliest signs to suggest that this is a significant in a small ASD, actually the ECG may be actually very normal, absolutely normal. So the first thing that suggests a significant shunt is the presence of this RSR dash pattern, which is present in lead V1 typically, but sometimes in V2 also. This is suggestive of volume overloading. Further, there is a slurring of the R dash, which is also suggestive of the volume overload. There is a prolongation of QRS, right axis deviation, because RA and RV are enlarging. The tall P wave is again suggestive of right atrial enlargement. And when pulmonary arterial hypertension starts to set in, there is an appearance of Q waves in V1, which is there. The chest X-ray shows enlargement of right atrial and right atrial enlargement, which we see in the AP view. Typically, we are always told, okay, more than 2.5 centimeters from the midline. If there is, RA extending beyond that, it is RA enlargement. But we need to understand that most of these X-rays these days are digital X-rays. So typically, there are 2 or 3 ways in which RA enlargement has been defined. So we see the RA is brooding in how many intercostal spaces. Generally, if it is more than 2 spaces, then RA is enlarged. And the other thing is to measure the distance of the beginning of, the right atrial border to the SVC junction. And if the distance from the diaphragm to the junction of RA to SVC is is more, then that is again suggestive of RA enlargement. As far as echo is concerned, we need to measure the QP and QS. I'm not describing how we measure the QP and QS. Generally, please remember that we measure the VTI or the velocity time integral across the flow of the flow across the pulmonary valve, and we measure the diameter. We feed in these two parameters, and the QP is given by the computer itself in the echo machine. And in the similar way, we measure the VTI across the aortic valve, aortic flow, and we calculate the ratio of these two. This is a very importantly and very commonly asked question as to what is the most important feature of a large atrial septal defect on echocardiography. So please remember that the mean gradient in a cardiac cycle, if it is less than 3 millimeters, that is suggestive of a large ASD. So one important take from this thing about ASD is that the mean gradient of less than 3, we all we asked so many students, and a very few of them answer this correctly, that it is the mean gradient between of the flow across the atrial septal defect, which is an important determinant of the size of the ASD. So this typically shows that right ventricular hypertrophy and an RSR dash pattern in lead V1. So this is typically suggestive of an ASD in a 6-year-old child. I tried to bring the audio of this. I don't know if it can be heard very well. My volume is maximum, but this is how we hear the flow across the pulmonary valve in a patient of ASD. Now, shifting gears to ventricular septal defect, we need to understand that clinically, a moderate to large VSD is almost always symptomatic. A very small VSD may not be symptomatic. In fact, your generation has not studied those series, but people of my generation, it was a part of our curriculum to study NHS 1 and NHS 2, the natural history study 1 and 2, which were the long-term follow-up studies on congenital heart diseases, of which VSD was an important part. The only major risk in small VSDs is of development of infective endocarditis. Otherwise, they carry a benign course. But when they are symptomatic, they are at least moderate to large VSDs. And these are the clinical signs of a moderate to large VSD, which include tachypnea, which was there in our baby that we discussed today, poor feeding. We did discuss about this, poor weight gain, which was again there, a degree of tachycardia. In our patient, it had probably settled down because of the treatment of the infection. Pulmonary rales or grunting, and retraction of the chest if the heart failure is marked. So on examination, we discussed the entire spectrum of the size of VSD. So typically, if the VSD is a minuscule VSD, very small, 1 millimeter maybe, or something that can be missed even on echo at times if it is hidden, then the murmur may be a very, very small murmur. It may be just a ejection systolic murmur. In general, as the VSD size increases, the loudness of the murmur decreases. The murmur becomes less and less loud. So, but the typical teaching is that the pansystolic murmur of VSD is associated with a thrill. The LV apex is better felt because the LV gets enlarged. We can imagine that the left ventricle is, pushing the blood into right ventricle, and the same blood is going across the pulmonary vasculature and coming and filling up into LA and then the LV. So LV apex is prominent. When the shunt is significant, the amount of blood that is getting shunted across the mitral valve is large enough to produce a MDM at the level of the mitral valve. And for the same reason, there is also an occurrence of the left ventricular third heart sound. So if somebody asks you clinically, how do you determine whether the shunt of VSD is more than 2:1 or not? So MDM at the mitral valve level and LVS3 are the single most important two important features which are suggestive of a large VSD. Of course, if the pulmonary arterial hypertension has set in and it is still in the hyperdynamic stage, then allowed P2. And as as we were discussing, as the pH keeps on settling in, the left to right shunt keeps on decreasing, and eventually the cardiac size becomes normal. The pulmonary plethora, which was seen in X-ray, that also reduces, and so the shunt size, the shunting amount of shunting keeps on reducing. As the right ventricular pressure increases, the left to right shunting decreases. So this is again from the uptodate.com. This tells you how do you determine what are the various features that you take into account when you find a holosystolic murmur at the lower left sternal border. So the first thing that we see is whether there is a RV parasternal impulse present alongside, the laterally displaced left ventricle. If it is present, then this is a large VSD. It is a significant VSD. Second thing we see is that if the single second heart sound is present, and if that is the case, then it is a VSD which is associated with pulmonary arterial hypertension. The third thing we see is there a diastolic murmur that is present? As I was discussing, if there is a mid diastolic murmur across the mitral valve, which is a flow murmur, then it is associated with a large VSD. And the last thing is if there is a third heart sound which is present, then that is again suggestive of a large VSD. So we should look first at the S3 and the MDN. Then we should be looking at the prominent RV parasternal impulse and LV lateral impulse. And finally, when the pulmonary arterial hypertension starts to set in, we get a single loud second heart sound. And this is how we hear the the pansystolic murmur of mitral of ventricular septal defect. I'm afraid, despite my best efforts, the sound is not so good from this recording. These are again from the uptodate.com, and you could go to the site and look at these recordings. So this shows a moderate to large VSD or a moderate VSD in which we see these equiphasic complexes in V3 and V4. These are suggestive of biventricular hypertrophy, and we can also see the RSR pattern in these. So if the VSD is very large, you would get a chest X-ray, something like this. And if it is a moderate VSD, you would get a lesser degree of cardiomegaly, and the X-ray would be something like this. Now, based on echo, mostly on echo, and sometimes because cath is not done unless there is a clear pulmonary arterial hypertension. As we can see here, and this point Dr. Kamal also brought out that moderate shunts are between if it is less than 1.5, it is not significant. And moderate shunts are beyond 1.5 to 2.2 or 2.3. If they're more than 2.3, the QPQS, then these are large shunts. There is also a classification given on the basis of size. But again, this is highly dependent upon the age and the size of the patient. The more relevant and less dependent upon the age is the ratio of the defect to the aortic annulus size. And if the size is between 0.25 to 0.75, the size of the aortic annulus, it is a moderate VSD. And if it is more than 0.75, then it is a large VSD. Another thing is the smaller the defect, the greater would be the flow gradient across the VSD. So if the gradient is more than 60 millimeters of mercury, then it is a small VSD. And if it is less than 40, it is a small VSD. In fact, we say that in very large VSDs, the pressure between the two chambers is equal. Another important question that your examiners like to know is they would say, what is the PA pressure what is the PA pressure if the gradient across is, say, 60? So all that you have to do is subtract the gradient of 60 from the systolic blood pressure of the individual, because that would be equal to the left ventricular pressure, and that gives you the pulmonary artery pressure or the RV pressure, unless there is a RVOT obstruction. We also need to understand that another important thing that we measure to see whether the shunt is large or not is the size of the left ventricular internal diameter in diastole, and we compare it to the compare it with the normal child with the similar expected weight. If the LV is dilated and the Z score, the ratio of the LV dimension of the child to the normal is more than 2, then that signifies a significant left to right shunt. Another important thing is that the left ventricular contraction starts first, and so we get a first bump in the flow, then somewhere the flow becomes less because the gradient decreases, and in the end there is again a push because the right ventricular flow again the right ventricular pressure again decreases, and so we get a M-shaped pattern in the flow across the VSD, and this is again suggestive of a non-restrictive VSD or a large VSD. Now, shifting gears to PDA, this is the typical Krichenko classification of PDA that we should know. This is more important because more and more of us are actually now going ahead and closing these defects using devices. So it is good to know about this particular classification. Again, the size of the defect is based on the ratio of the flow across the pulmonary valve to the systemic flow, and anything which is more than 2.2 or has associated pulmonary arterial hypertension is a large duct, and those which are moderate with a QPQS between 1.5 and 2.2 generally lead to LV overload. But if they are more than 2.2, then they lead, besides overload, they lead to pulmonary arterial hypertension. So the clinical features again in PDA are similar to VSD, including signs of heart failure, poor feeding, poor weight gain, and respiratory distress. And an older child may actually present with shortness of breath or easy fatigability. Now, when we, again, please remember that the blood is going from the aorta into the pulmonary artery. This is again a very often asked question. Where would you expect the pulmonary arterial hypertension to occur earlier? It would be actually in this particular condition, because the pulmonary artery, both during systole and diastole, is subjected to systemic pressures. So we have a torrential flow across the ductus arteriosus, and that leads to a dynamic left ventricular impulse, which is usually associated with a thrill. Because the flow from the aorta does not, all of it does not reach the periphery and is getting bypassed through the duct into the pulmonary artery. So the pulses are bounding with a wide pulse pressure. The second heart sound may be split with an accentuated B2, particularly when the pulmonary arterial hypertension starts to set in. Then there may be occurrence of eddy sounds in the late systole and early diastole. And there is generally, with significant shunts, how do we say the shunt is significant? There is a grade 4 associated with thrill, continuous murmur in the infraclavicular region. And there also, because just like VSD, there can be a apical diastolic rumble, which is preceded by the third heart sound. So similar to a ventricular septal defect. This is again a continuous murmur across PDA. This is also taken from the uptodate.com, and if you can't hear it right now, you can go back to the site and see this. Now, shunt quantification across the PDA. Uh, One thing that we look for in the echo is actually the LA to aorta ratio. And if it is more than 1.5, then it is at least a moderately large PDA. We also look at the LV dimensions, which will get increased. We also look at the QPQS, and we also look at the PDA pressure gradient if we can. Um, but that is again a difficult to view kind of scenario. The important thing to understand is that in VSD and ASD, we measure the QP and the QS directly, the pulmonary flow and the aortic flow. However, in case of PDA, it is reversed. The right ventricular outflow actually is equal to the systemic blood flow, and the pulmonary blood flow that we measure is actually equal to the left ventricular output. And so the ratio of these two in an isolated PDA gives us the QPQS in patent ductus arteriosus. So this is another question that is sometimes asked, that okay, this is the continuous murmur of PDA. How do you know? How do you know what is um, what is the estimated pulmonary artery pressure? Now, if this is the gradient across the PDA, you subtract this from the systemic pressure or the aortic systolic pressure, and that gives you the pulmonary artery pressure, which is 36 in this particular case, where the peak gradient across the patent ductus is 32 millimeters of. So that is it. If there are any questions, I would take them, but my effort today has been to see how clinically and on the basis of routine investigations we can, quantify the shunts and see which shunts are significant. Thank you, and any questions I will take.
Thank you, sir. Thank you. Beautifully covered all the aspects, including how to quantify various studies. You covered upon the NHS1, NHS2. You also talked about the various series, including murmurs, significance, and its clinical correlation for quantifying the severity. So, thank you very much, Dr. Bansal. Dr. Mahajan, if you have any
Yes, I am
comments.
there.
Yes, yes.
It was
Hi,
very
Ajay.
excellent talk.
Hello, Ajay.
Yes, sir.
Hi.
So, sir, Dr. Mahajan, you have any other questions to him?
No, no.
Okay. So I think, Dr. Bansal, it was very well covered. Uh, you have already highlighted very important questions and the answers also in your presentation. Um, if you can just tell students as to what are the other important aspects that they should know with regards to X-ray ECG, which is in a patient with left to right shunt, to differentiate between a VSD, PDA, and an ASD. Based on these two ECGs we discussed when Dr. Mohit was presenting, X-ray, if you can tell about the chamber enlargement and differentiating between
Yeah.
the two.
So, see, typically, and a so let us take a condition when there is an increased pulmonary blood flow occur. So let us discuss these set of patients in two scenarios. One is when the pulmonary artery, the flow across the pulmonary vasculature is increased, but the pulmonary arterial hypertension has not set in, or the Eisenmengerization physiology has not set in. So in that case, in ASD, you would get RA and RV enlargement, number one. So the RV will form the apex, and you will have that typical acute angle between cardiophrenic angle in this, and there will be some degree of cardiomegaly. there would be plethora, but not as much as you would see in ventricular septal defect. In a VSD, it would be a LV type of apex with a prominent plethora. And depending upon the degree of shunt, there would be degree of cardiomegaly. In case of duct, again, the features would be a left ventricular type of apex and cardiomegaly associated with increased plethora. Now, as the isomerization starts to set in, the um, ventricular septal defect is usually associated with a decrease in the cardiac size and a greater prominence of the proximal pulmonary arteries, or pruning as we call the peripheral arteries start to show up less and less, and the central arteries become more and more prominent, and the cardiac size starts to decrease. So that happens in pulmonary in VSD. In case of atrial septal defect, this is the one condition where cardiomegaly may persist. And the reason for that is that with increasing pulmonary arterial hypertension, in about 50% of the patients, tricuspid regurgitation develops. So the cardiomegaly may continue in the patient of atrial septal defect. The patent ductus arteriosus, when it starts to isomegerize, again, the plethora starts to decrease, the cardiomegaly starts to regress, and um, there is a peripheral pruning along with increasing prominence of the central arteries. If there are any things that I've missed, you may please chip in.
No, I think you have beautifully covered the cardiomegaly, plethora, chamber enlargement, and as you said, it's the volume which will determine which chamber will enlarge how much, and level of shunt which will determine which chambers will enlarge. So in ASD, you
Sure.
will expect RA, RV, PA, VSD, RV, and PA, and a PDA, the LV side, because the duct and the aorta and the PA, and then the LV, not the RV side. So that's how probably in the pre-ACO era, we all used to determine the shunts based on, apart from the murmur and clinical examination, as to which chamber and where the shunt lies. So thank you very much, Dr. Bansal. On behalf of myself and Dr. Ajay Majan, I
Thank
thank
you.
you for giving this time and opportunity
Thank you.
to us to interact with you and learn from you. And I also thank Dr. Mohit Goel for presenting his case today to make this a learning platform. So thank you very much,
Thank
everyone.
you.
We look forward to
Bye.
have you
Bye.
again.
Thank
And
you.
the next session would be lecture series 4, 24th of October 2024, with one
Thank you.
more expert with us. Can we have the next slide of all the topics? Uh, this is our series, how it runs. So next time it's going to be Dr. Maulik from UN Mehta Institute of Cardiology. He'll be presenting a case of palate physiology. Dr. Professor Aditya Kapoor from SGPGI will be our expert faculty, and he'll be talking also about management approach to palate physiology. Time is going to be 8 p.m., and we look forward to have a blockbuster Thursday, 8 p.m. on 24th of October. Looking forward to have you all for learning ahead. Thank you. Take care and good night. Good night,
Thank
sir.
you. Good night.